This is Andrew Shorr at the Washington Hospital Center with your literature update in pulmonary and critical care for the month of November. There are two articles I'd like to discuss today, both from the Annals of Internal Medicine in the November 18th issue. The first study, by Menzies and colleagues, looked at issues related to treatment for latent tuberculosis infection, or LTBI. These authors conducted a prospective randomized open-label study comparing the use of 4 months of rifampin to 9 months of isoniazid. 9 months of INH is currently what's recommended. In the past, we used to use a short course therapy, or some considered using a short course therapy with RIF and PZA, but that was discontinued because of severe hepatotoxicity. One of the concerns with 9 months of INH, of course, is the risk for hepatotoxicity, even though it's small. Could it be made smaller? And conversely, when you use 9 months of INH, compliance for an extended period of time becomes very, very difficult to ensure. So these authors were interested in looking at what proportion of patients actually completed therapy, whether they were randomized to 4 months of RIF or 9 months of INH, and what was the incidence of severe liver disease or severe hepatotoxicity in terms of grade 3 or 4 issues. One of the strengths of this study was that it was multi-center, and another strength was that they did not exclude older patients or patients with kind of marginal risks for hepatotoxicity. They tried to be all-inclusive. What the authors found was that the risk of hepatotoxicity with 9 months of INH was about 4%, versus 2% with rifampin, and that 2% absolute risk difference was statistically significant. The other thing the authors noted was that about 80% of patients who took 4 months of RIF completed therapy successfully, versus about 60% of patients who were randomized to INH. That 20% absolute risk difference indicates that for every 5 patients who you treat with rifampin for 4 months, as opposed to isoniazid, you'll get 1 additional person to actually complete their course of therapy, and that would be a major advance. Now, this study did not look at actual rates of active tuberculosis in terms of the development of that. This was just essentially a proof of concept study to look at safety, and very much a hypothesis generating study to look at tolerability overall. The data, I think, is important to clinicians because it suggests that eventually RIF for 4 months may be acceptable. It also suggests that rates for INH hepatotoxicity are actually low at about 4% in a very mixed population, but they might potentially be made lower with rifampin. And again, the study shows that even if you're compliant, or even if you're aggressive about enhancing compliance, with 9 months of therapy, only about 60% of patients complete a course. The next study I want to talk about looked at a very different issue. It looked at postthrombotic syndrome or postphlebitic syndrome following DVT. This was by Kahn and colleagues. It was a multi-center study, observational in nature, across many centers in Canada, led by the group of investigators who were noted leaders in the field of deep vein thrombosis and PE. And they were interested in just looking at the prevalence, or rather, in this case, the incidence of postthrombotic syndrome, which was very well defined based on a risk scoring tool, and also looking at predictors of it. What they found was that about 30% of patients with a DVT do develop some form of postthrombotic syndrome. In the vast majority of patients, it's mild, though. Only about 3 to 4% of patients develop severe postthrombotic syndrome. In addition, when they looked at risk factors, the risk factors that were important for postthrombotic syndrome included things such as patient age, and in addition to patient age, things such as the extent of the clot and female gender. So it does suggest that perhaps you may want to be more aggressive in select group of patients, so patients with big clot, in terms of early use of compression stockings, because there's probably no harm to that. There may be a little bit of benefit, but of course that would require a formal randomized controlled trial to test in terms of the benefit of compression stockings at preventing postphlebitic syndrome. In the end, though, I think you do need to counsel your patients that this is a risk they need to be aware of, and they should seek evaluation for it as soon as possible. And it also suggests that there is a burden to DVT that we don't always measure from a hospital-based perspective. So in sum, those are the two studies I'd like to discuss with you for this month. This is Andrew Shorr from the Washington Hospital Center, and I hope everybody has a happy holiday season.